Good morning. It's a great pleasure for me to take part in this session, joint session with the European Heart Society. The topic of silent myocardial ischemia has a long history, and we are very proud that our group in Jerusalem was actually the first to describe silent ischemia together with Professor Stern. And then we had demonstrated already in 1974, and then we demonstrated that these STT changes on Holter monitoring are associated with pathological finding on coronary arteriography. Then we published several papers on the prognostic significance of these ischemic changes, both in patients after myocardial infarction and in patients with stable coronary artery disease. Later on, we showed that these STT changes that represent ischemia, we found that the ischemic threshold varies during daily activity in patients with coronary artery disease. And then other groups as well, many groups actually as well, found that silent ischemia was associated with increased mortality in high-risk post-infarction patients. This is the group from Baltimore by Gottlieb, published in JAMA. And then Peter Cohn assessed also the prognostic significance of asymptomatic ischemia and actually popularized this subject, which became a very hot topic for many years. This is another study by Rocco and Betsy Nabel, and that assessed the prognostic significance of myocardial ischemia in patients with stable coronary artery disease. And you see that after 2 years, there was a different prognosis of patients who had ischemia compared to patients without ischemic changes. Gill and co-workers several years later published a paper in the New England Journal of Medicine, assessed ischemia detected by ambulatory monitoring in patients after myocardial infarction. They studied 406 patients who had both Holter monitoring and stress test. And they found that the presence of ischemia on Holter monitoring was associated with adverse outcome, which included death, non-fatal myocardial infarction, and the development of unstable angina. Then a larger study was reported by Morse and co-workers in a study that we also participated in, the MISMIT trial that was published in JAMA. He assessed by four non-invasive tests, resting ECG, ambulatory ECG monitor, exercise test, and thallium 201 scintigraphy, patients late after acute coronary event who were in stable condition, 936 patients, and the follow-up was 2 years. And contrary to the previous study, in this study, the presence of ambulatory ischemia on Holter monitoring carried no prognostic significance. Some changes in the ECG carried prognostic significance, while changes on the stress ECG did not carry prognostic significance. Thallium 201 scintigraphy had only borderline significance. As the subject of silent ischemia was very hot, many medications were studied, and for example, we assessed the effect of calcium antagonist nizolidine on ischemia detected by Holter monitoring and exercise testing, and we showed that this drug was highly effective. This calcium antagonist of Bayer was highly effective in suppressing ischemia. Another study on the effect of various preparation of metoprolol on ischemia also was highly effective. A later study on a new calcium antagonist, a T-channel calcium antagonist, mibefradil, was compared to amlodipine in suppressing both exercise and daily ischemia. 309 patients. The study was published in Circulation, and what we saw is that the mibefradil was highly effective in reducing the number of ischemic episodes by 50 to 88%, and the duration of ischemia by 40 to 70%. However, this drug was removed from the market because of various reasons that we will not talk about it now. Prakash Didwania published a few years ago a paper on the effect of intensive versus moderate lipid-lowering therapy on myocardial ischemia in elderly patients with coronary artery disease. This is the SAGE trial. These are patients above the age of 65, almost 900 patients. These patients had evidence of myocardial ischemia on Holter monitoring, and they were randomized either to receive atorvastatin 80 milligram or pravastatin 40 milligram, and the follow-up was 1 year. As we can see here, both medications, both pravastatin and atorvastatin, were effective in suppressing myocardial ischemia on Holter monitoring. And compared with moderate pravastatin therapy, intensive atorvastatin therapy was associated with reduction in cholesterol, major acute cardiovascular events, and death. And in addition, the high dose of atorvastatin reduced the amount of myocardial ischemia. Actually, both drugs reduce it. The effect of PCI on silent ischemia was after myocardial infarction was assessed in the Swiss registry. These are 201 patients after recent myocardial infarction with evidence of silent myocardial ischemia were studied, and these patients were randomized either to have PCI or intensive anti-ischemic therapy. And as we can see, PCI was more effective than medical therapy in reducing cardiac events. And those cardiac events actually were hard endpoints. We can see here that these endpoints were cardiac death, non-fatal recurrent MI, symptom-driven revascularization, and angina, and also unstable angina. And they concluded that among patients with recent MI, silent myocardial ischemia, as verified by stress imaging, and patients with 1 or 2 vessel coronary artery disease, PCI is superior to medical therapy in improving long-term outcome. You are all familiar with the COURAGE trial. In this study assessed in patients with stable coronary artery disease whether medical management compared to PCI carried different prognostic information. And the trial involved more than 2,200 patients who had objective evidence of myocardial ischemia and significant coronary artery disease. These patients were randomized either to undergo PCI plus optimal medical therapy, these are the PCI group, and half of the patients were randomized to receive just optimal medical therapy. And as we can see, during a mean of 5-year follow-up period, there was no difference in outcome in this group of patients. Survival free from death and any hospitalization was similar. Actually, all outcomes were similar in the 2 groups of patients. A year later, Shaw and co-workers analyzed this study. In the COURAGE study, there was a nuclear sub-study, and the nuclear sub-study compared again the optimal medical therapy to PCI, and in this sub-study, 314 patients had 2 myocardial perfusion scintigraphy, one before beginning of study, and the second one 6 to 18 months later. And as we can see, patients who were on optimal therapy at the end of the study, 27% of them had evidence of intermediate or severe ischemia compared to only 16% of the patients who received PCI plus optimal medical therapy. And the authors came to the conclusion that in the COURAGE trial, patients who underwent serial myocardial perfusion scintigraphy, in this group of patients, adding PCI to optimal medical therapy resulted in a greater reduction in ischemia compared to just optimal medical therapy. This was patients with ischemia reduction had lower unadjusted risk for death or myocardial infarction. When it was adjusted, this difference was not significant. However, if they took only patients with moderate to severe ischemia, this difference was borderline. And the clinical perspectives are that the message from the Courage trial remains that PCI may be safely deferred in patients with stable coronary artery disease, but the message may be redefined such that patients with substantial residual ischemia on optimal medical therapy should be considered for crossover to PCI. In our daily life, actually, all of us screen for ischemia all the time. We are being asked to screen for ischemia. Patients who ask us whether they can go to the gym, whether they can undergo surgery, and actually all of us do it daily, whether it is indicated or not indicated. We do it also for medical legal reason. And I think that we should screen mainly high-risk patients, and I think that one of the group is patients with diabetes. And this is the DIAD trial that was published in JAMA about 2 years ago, screened patients with type 2 diabetes and no symptoms of coronary artery disease. More than 1,100 asymptomatic diabetic patients were randomized to either screening by stress myocardial perfusion imaging or not to be screened. And the aim was to test the hypothesis that screening would identify higher risk individuals and beneficially affect their risk of myocardial infarction or even cardiac death. And what the author found that among the 560 patients who were screened compared to patients who had no screening, there was absolutely no difference in outcome in these patients. And therefore, the conclusion that in this study, patients with diabetes, the cardiac event rates were low and were not significantly reduced by myocardial perfusion screening for myocardial ischemia, and the follow-up was 4.8 years. The French guidelines for detection of silent myocardial ischemia in patients with diabetes suggest that screening for silent ischemia should not be performed in patients with diabetes unless they have one additional risk factors. And actually, the American Heart and the College and the European guidelines do the same. They advocate screening for silent ischemia in patients with diabetes only if they have one or more risk factors for coronary artery disease. The largest ever performed study on silent ischemia was reported in JACC about 2 years ago. This is the Merlin trial that assessed the relationship between ischemia detected on continuous ECG monitoring and cardiovascular outcome in patients after acute coronary syndrome. The study involved more than 6,500 patients who were hospitalized with non-ST elevation ACS. Those patients were randomized to receive either ranolazine, which is an anti-ischemic drug, or placebo in the Merlin TIMI 36 trial. And in this study, all patients had continuous ECG monitoring for 7 days after randomization. The follow-up was 1 year. There is no such study, and I don't believe that there will be such a study in the future. And as you can see, in patients who had no, the best prognosis and outcome was in patients who had no ischemic episodes on Holter monitoring during the 7 days of monitoring. Patients who had up to 2 episodes had better prognosis than patients who had more than 2 episodes, ischemic episodes. And following this paper, we wrote an editorial together with Mitch Krukov in JACC. And we said that this study strongly confirms that transient myocardial ischemia have prognostic significance for ACS patients treated medically and or undergoing PCI, and patients who are otherwise categorized as high or low risk. Despite the very clear prognostic value of this information, at present it is not practical to perform continuous ECG in all ACS patients, as accurate and reliable online automated ischemia detection systems are not available. We also think that even if And when such systems are developed to go beyond research application, it will be critical to show that continuous ECG-guided therapy actually can lead to improved outcome. In summary, silent ischemia is prevalent in patients with coronary artery disease. Stress testing, we think, is the preferred method of detection. Prognosis is adversely affected by ischemia regardless of whether the patient is usually symptomatic or asymptomatic. A variety of pharmacologic agents can reduce the ischemic burden, but as of yet, there are only limited data suggesting that such therapy improves prognosis. By contrast, myocardial revascularization, especially CABG, and probably also PCI in patients with evidence of significant ischemia appear to improve longevity. I think that screening for silent ischemia should be reserved to a high-risk group and among patients with non-coronary artery disease. These, as I mentioned, these are patients with diabetes and at least one risk factor, patients who have significant peripheral vascular disease, patients after stroke, patients with multiple risk factors. Screening for ischemia, which probably represent higher risk group, screening for ischemia in patients with coronary artery disease, I believe should be performed in patients after myocardial infarction, patients who had PCI, and patients who had CABG. I think that screening for ischemia in a very large cohort of individuals, as is being done in the regular practice, I think we are doing many, many unnecessary tests for ischemia, and I believe we should reserve this testing only for patients at high risk. Thank you for your attention.